My name is Molly Perencevich, and I'll be talking about peptic ulcer disease. I have no disclosures to report, but I will discuss the use of medications for non-FDA approved indications. H. pylori and NSAIDs result in 90% of peptic ulcer disease. They have overlapping mechanisms that cause peptic ulcer disease. H. pylori has enzymes that cause cellular damage and alter the mucus layer. This then causes pro-inflammatory cytokines in a chronic inflammatory cascade, resulting in mucosal damage and ulceration. H. pylori also causes increased gastric acid production, which also results in mucosal damage and ulceration. NSAIDs result in both systemic and topical effects that reduce COX-1, which then decreases prostaglandin, and this results in increased gastric acid production and similarly mucosal damage and ulceration. Decrease in prostaglandin also results in decreased mucus production, decreased bicarbonate, decreased blood flow, and increased neutrophils, all of which contribute to mucosal damage and ulceration. There are other risk factors for NSAID-induced peptic ulcer disease. These include older age, a prior history of peptic ulcer disease, smoking, and this risk is proportional to the amount smoked, and several medications that are used in combination with NSAIDs, including corticosteroids, anticoagulants, antiplatelets, SSRIs, and bisphosphonates. Some systemic diseases such as COPD, cirrhosis, mastocytosis, and uremia also increase the risk of NSAID-related peptic ulcer disease. There are several things to note about the association between H. pylori and peptic ulcer disease. First, the location of the H. pylori in the stomach impacts the location of peptic ulcer disease and the risk for gastric cancer. When H. pylori involves the antrum, which is the lower part of the stomach, this results in increased gastrin level, which then causes increased acid levels. There's little or no atrophy in the stomach, and the ulcer tends to occur in the duodenum, and the gastric cancer risk is low. However, when H. pylori involves the corpus or body predominantly, this is the middle part of the stomach, there's atrophy. This results in decreased acid. This results in decreased gastrin levels. The ulcer location tends to be in the stomach, and the risk for gastric cancer is higher. Because of the association of peptic ulcer disease with H. pylori testing should be done in all patients with peptic ulcer disease. Ideally, you have 2 negative tests to feel confident that the patient does not have H. pylori. And it is known that bleeding and PPI therapy may decrease the sensitivity of testing, and there's more coming on this. We also know that treatment of H. pylori helps heal ulcers and prevent recurrent ulcers. There are other causes of upper GI ulcers that we should keep in mind, especially when a patient does not clearly have H. pylori or using NSAIDs. This includes malignancy, which tends to occur more commonly in gastric than duodenal ulcers, gastrinomas, also known as Zollinger-Ellison syndrome, and I'll talk about this in a moment, infiltrative diseases such as Crohn's disease, mastocytosis, and sarcoid, viral infections such as CMV and HSV, vascular disorders such as vasculitis and cocaine use. Patients who've had a Roux-en-Y gastric bypass can get what's called a marginal ulcer at the anastomosis. Radiation therapy can cause ulceration, as well as stress ulcers that occur largely in patients who are intubated in the ICU. A quick note about gastrinoma, also called Zollinger-Ellison syndrome. This is a neuroendocrine tumor that tends to occur in the duodenum or the pancreas. It results in hypergastrinemia, which causes increased acid secretion. Patients often have peptic ulcer disease, which tends to occur in the duodenum or the jejunum more than the stomach. They also often have diarrhea and gastroesophageal reflux disease. This is usually sporadic, but MEN1 syndrome occurs in 25% of cases, so this should be considered. The diagnosis is typically made on a elevated fasting gastrin level, as well as cross-sectional imaging to find the neuroendocrine tumor. There is a differential for an elevated gastrin level that should be considered. These include hypochlorhydria from PPI or atrophic gastritis, so these things should be assessed for before considering the diagnosis of gastrinoma. Peptic ulcer disease can present in many ways, including uncomplicated and complicated disease. Patients can be asymptomatic, and they can also have symptoms of dyspepsia or upper abdominal discomfort. Gastric ulcers tend to hurt more with eating food, so patients tend to eat less and therefore lose weight. Duodenal ulcers actually tend to feel better when patients eat food, so they tend to have pain 2 to 3 hours later, and patients tend to eat more and gain weight. Complications of peptic ulcer disease include bleeding. This occurs in 10 to 15% of patients. This can be overt, meaning blood that you see in the form of coffee ground emesis, hematemesis, melena, and hematochezia, or occult bleeding, bleeding that you don't see in the form of heme-positive stool or iron deficiency anemia. Peptic ulcer disease can cause perforation, resulting in peritonitis or shock. It can also cause penetration into surrounding organs, such as the pancreas, the duodenum, causing a gastroduodenal fistula, or vascular structures, which can cause significant bleeding. Lastly, peptic ulcer disease can cause obstruction, resulting in nausea, vomiting, early satiety. The diagnosis of peptic ulcer disease is most commonly made on endoscopy. This is considered the most sensitive test. When we do an endoscopy, we look at the ulcer to determine whether it appears benign or malignant. This is a picture of a very benign appearing ulcer. It has very clear borders, does not have any features that appear malignant. However, we should be biopsying the ulcer if there are any malignant features, as well as to potentially avoid a follow-up endoscopy if we can adequately prove that the ulcer is not malignant on initial endoscopy. And as I mentioned before, gastric ulcers tend to have a higher risk of malignancy than duodenal ulcers. It's also very important that the gastroenterologist biopsy the surrounding gastric mucosa to evaluate for H. pylori and other predisposing conditions. Imaging can also be used to diagnose a peptic ulcer. CT is done if there is a concern for perforation, penetration, or obstruction. And an upper GI series with barium can also be done. It tends to be less frequently performed given the relatively easy access for endoscopy, and it is less sensitive for small ulcers, but if there is a patient for whom endoscopy is not a good test, this could be considered. When we see an ulcer on endoscopy, we as GI doctors classify these ulcers based on stigmata of recent bleeding, and we then use this to determine endoscopic treatment as well as medical therapy. So these three things listed here are different classifications of ulcers that tend to have higher risk criteria. These are ulcers that we are concerned are going to have a higher risk for rebleeding or that may not be able to be adequately treated. Because they have these higher risk stigmata, we then use endoscopic therapy, which tends to be a combination of things like epinephrine injection as well as mechanical clips or coagulation therapy. And then these patients who have these higher risk ulcers also are the ones who need IV PPI for 72 hours after the endoscopy before they can be transitioned to PO PPI, oral PPI. The last three here, these classifications of peptic ulcers are considered lower risk criteria. These ulcers, we tend to worry less about having rebleeding or significant ongoing bleeding. These patients may be treated with one form of therapy, such as clips or coagulation, or no endoscopic therapy. And these patients can be transitioned immediately to oral PPI. This is a picture of an actively bleeding ulcer. And the therapy for this ulcer included injecting epinephrine and then using these mechanical clips to pinch off the vessel to stop the bleeding. This is a picture of a flat spot on an ulcer and a clean-based ulcer. These are considered low-risk ulcers, and so no endoscopic therapy was needed here, and the patient was treated with standard dose PPI. Of note, if a patient comes in and has an ulcer while already on PPI, they may need a higher dose, and I'll talk more about this. In terms of H. pylori, there are several ways of testing, and this becomes something we need to think about when we have a patient with peptic ulcer disease. The non-invasive tests include a blood serology, which is an IgG, a urea breath test, and a stool antigen. The serology tests for past and active infection, while the urea breath test and the stool antigen only test for active infection. The sensitivity for the serology is quite good, but the specificity is a little bit lower at 75 to 95%. There are rarely false negatives. These can occur in the elderly or those with cirrhosis. But importantly, this test is not affected by antibiotics, bismuth, H2 blockers, or PPI. The big concern with the serology test is because it tests for past infection, not just active infection, there can be false positives, patients who have a positive test but don't actually have active disease. And because the positive predictive value in the US is about 50%, where the prevalence is less than 20%, you may be treating some patients unnecessarily with antibiotics, which is something we'd like to avoid if possible. Because it tests for past infection, you can't use this to test for eradication, but it is easy and cheap as a blood test, relatively easy and cheap. The urea breath test has a sensitivity and specificity that are both in the 90th percentiles. There are false negatives, importantly, and this is something we need to think about when we use this test. Antibiotics and bismuth need to be off for 4 weeks. PPI needs to be off for 2 weeks. And we're not sure about H2 blockers. At this point, they may decrease sensitivity, and I generally recommend that patients be off of these for 48 hours. It's also possible that active GI bleeding may decrease the sensitivity of the breath test. This test can be used to test for eradication because it only tests for active infection, but it may not be as easily available as it involves a technician to do the test. The stool antigen also has quite good sensitivity and specificity similar to the urea breath test. It has the same issues with false negatives around antibiotics, bismuth, PPI, and possibly H2 blockers. And it also may have a false positive in the setting of active GI bleeding. Again, you can use this test to test for eradication, and it requires a stool sample. There are several endoscopic tests we can do as well. The biopsy urease test also tests for active infection. It has its test characteristics similar to the urease breath test, but also has the same false negatives, including PPI and antibiotic use. The histology and immunostain are considered the most sensitive and specific tests and generally considered the gold standard for H. pylori diagnosis. It is possible that the sensitivity is decreased with antibiotics and bismuth as well as PPI and H2 blockers, but less so than the other tests, and therefore is considered the most sensitive test in patients that are on those things. And the sensitivity may also be decreased by GI bleeding, but still we feel fairly confident that we're able to diagnose it if we take adequate GI sampling of the gastric mucosa. And again, we can test for eradication if endoscopy is indicated. So ideally, we want 2 negative tests for H. pylori in patients with peptic ulcer disease to feel confident that the patient does not have H. pylori. This most often includes a gastric biopsy done during the endoscopy, as well as potentially an H. pylori antibody. The concern with the stool antigen and breath test is that PPI, as well as GI bleeding, may decrease the sensitivity of these tests, and there's also a concern that GI bleeding may cause a false positive stool antigen. So as a result, the gastric biopsies ideally should be done by GI, and then you can consider the serology test as a second test. For medical treatment of peptic ulcer disease, PPI and H2 blockers can be used, although PPI tends to have a stronger effect on peptic ulcer disease healing. The dose is typically a standard dose, meaning something like omeprazole, 20 to 40 milligrams a day, although you may need to use a higher dose if the patient was already on PPI when they developed the ulcers, or they need to stay on precipitating medications. The duration tends to be 8 weeks for a gastric ulcer and 4 weeks for a duodenal ulcer, but this may need to be longer if you can't remove the precipitating factor or the ulcer is idiopathic. We also want to avoid NSAIDs and aspirin if possible, although this is not possible in all patients. This is a nice diagram that was published in New England Journal that outlines what we should do for long-term management of peptic ulcer disease in different situations. So if a patient has H. pylori infection, the therapy for H. pylori infection is given, and then there should be a documentation of cure of H. pylori, and then you can discontinue anti-secretory therapy such as PPI. They don't need to be on that long-term. If patients were taking NSAIDs other than a low-dose aspirin, you're going to ideally discontinue those NSAIDs, but if patients need to continue them, patients can be on either a COX-2 selective NSAID, or you can add a PPI to standard NSAIDs. If a patient is on low-dose aspirin for prevention of cardiovascular events, if this is for primary prevention, you're going to want to discontinue the aspirin in most patients. And for secondary prevention, you're going to want to resume the aspirin within 1 to 7 days for most patients and likely continue PPI therapy in the long term. If someone has an idiopathic ulcer, you're probably also going to want to continue low-dose PPI in the long term. I'm now going to review H. pylori treatment briefly. In 2007, the recommendations for first-line therapy was triple therapy. This was amoxicillin, clarithromycin, and PPI. It was typically a two time per day regimen for 7 to 10 days, although now it is recommended to do a full 14 days if you use triple therapy. However, the concern is that it now fails in 20 to 30% of patients, mostly due to clarithromycin resistance. And some guidelines would say things like use where clarithromycin resistance is low, which was defined as less than 15%. But the reality is we don't usually have this local data to make our treatment decisions. In 2007, the second line regimen was quadruple therapy. This is metronidazole, tetracycline, bismuth, and PPI. It's a 4 time per day regimen for 14 days. Occasionally tetracycline is not available, and then we can consider using doxycycline. There is some resistance to metronidazole, but this seems to be more easily overcome using these regimens. In 2017, the American College of Gastroenterology, one of the major GI groups, published new H. pylori treatment guidelines for the US. These are a little more complicated than the old ones, and it's important to consider a couple of key questions at the beginning. The first is there a penicillin allergy? And the second, does the patient have macrolide exposure for any reason? Now, the second question is a little bit of a hard one to answer. Since we know that patients probably get H. pylori infection as a child, pretty much any antibiotic that they've gotten since childhood could impact the resistance of the H. pylori that's been living in their stomach. Unfortunately, many patients don't remember what antibiotics they've gotten during their life. They may remember what they got last year, but they may not remember what they got 10, 20 years ago. And so we can try and do our best around this. We can ask patient questions, we can look through their medical chart, but the reality is we may not actually know if a patient has received a macrolide or not. So with these questions, you're then going to think about the treatment. If the patient has no penicillin allergy and no macrolide exposure, you have a couple options, including bismuth quadruple therapy, or you can potentially still use clarithromycin triple therapy. If a patient has no penicillin allergy but does have a macrolide exposure, you're going to want to avoid that clarithromycin, and generally the first line regimen would be bismuth quadruple therapy. If a patient has penicillin allergy but no macrolide exposure, you can consider triple therapy with clarithromycin and metronidazole instead of amoxicillin, but in general, people lean more towards bismuth quadruple therapy in this context. And if a patient has both penicillin and macrolide exposure, you're going to end up using bismuth quadruple therapy. This guideline also recognizes that given limited information on the antibiotic resistance in the US, we should assume that clarithromycin resistance is greater than 15% unless local resistance is known, which again, it generally is not. And therefore, we should generally avoid triple therapy, and generally quadruple therapy is being used as first line. Lastly, and I think importantly, this guideline recommends that we consider penicillin allergy testing. Many patients have penicillin allergy listed in their chart, but don't have a true penicillin allergy. If they're tested for this and are then able to take penicillins, patients will be able to take amoxicillin, which is considered a very effective agent against H. pylori, and in basically all regimens outside of bismuth quadruple therapy. It's also important that we try and prevent treatment failure for H. pylori. We want to think about resistance, especially to clarithromycin, metronidazole, and levofloxacin, and generally avoid antibiotics that patients have already received. At least these three. You can reuse amoxicillin and doxycycline, and tetracycline, as these antibiotics tend to have much lower rates of resistance. We want to explain the regimen and reinforce compliance to our patients. And we also want to consider sensitivity testing. This has become something that we're increasingly able to do, although it's not entirely clear at what point in the patient's care we should be doing it. Is it after they've failed 2 regimens or 4 regimens? So this is still an evolving area. To do this generally requires doing a culture, which is quite difficult. It requires a special endoscopy and processing of the sample, but this is increasingly available via commercial labs. The future will be with molecular testing. This is when we can actually test the H. pylori bacteria itself for certain mutations, genetic mutations that predispose and indicate that the bacteria has certain antibiotic resistance. In terms of the follow-up of peptic ulcer disease after you've diagnosed it, it is generally recommended that patients get another upper endoscopy to ensure healing of the ulcer and to make sure the ulcer is not malignant. If a gastroenterologist has adequately biopsied an ulcer during the initial endoscopy, this may not be necessary, but many endoscopists find it difficult to biopsy a bleeding ulcer as they're concerned that it will cause more bleeding, and generally end up recommending that we should do a follow-up endoscopy to make sure that it's healing, and again, make sure it's not malignant. Of course, if there's any malignant features, we would recommend that the gastroenterology biopsy that in order to expedite care. For patients who have gastric ulcers, we generally recommend doing the endoscopy after 8 to 12 weeks. But for duodenal ulcers, we actually don't recommend that the endoscopy necessarily needs to be done, because duodenal ulcers have a much lower risk of malignancy. So in general, if a patient has a duodenal ulcer that's thought to be likely due to NSAIDs or H. pylori and it does not appear malignant, a follow-up endoscopy does not need to be done. However, if it looks unusual, if there's any concern for malignancy or no clear cause, then it would generally be recommended to do it. We also want to test for H. pylori eradication. This includes biopsying the gastric mucosa during a follow-up EGD if that is performed. If a follow-up EGD is not performed, the non-invasive testing can be done to evaluate for H. pylori eradication. with a stool antigen or a urea breath test. This needs to be done 4 to 8 weeks after treatment and off antibiotics, as well as off PPI for 2 weeks and possibly H2 blockers for 48 hours. This is all needs to be done to ensure you don't get a false negative stool antigen or breath test. Now I'm going to ask a couple of questions about peptic ulcer disease. The first is, a 24-year-old woman presents with melena and is found to have anemia with a hematocrit of 31%. She's been taking NSAIDs 2 to 3 times per day for recent knee pain. She is treated with a PPI and an upper endoscopy shows a clean-based ulcer in the stomach. H. pylori testing is negative. In addition to stopping NSAIDs, what treatment do you recommend? A, omeprazole 20 milligrams twice a day for 8 weeks, then continue the 20 milligrams daily indefinitely. B, omeprazole 20 milligrams daily for 4 weeks, then stop the PPI. C, omeprazole 20 milligrams daily for 8 weeks, then stop the PPI. D, omeprazole 40 milligrams twice a day for 8 weeks, then continue 20 milligrams daily indefinitely. And E, omeprazole 40 milligrams twice a day for 8 weeks, then stop the PPI. I'll give you a minute to answer the question. The answer is C, omeprazole 20 milligrams daily for 8 weeks, then stop the PPI. In a patient with a gastric ulcer likely due to NSAIDs, the recommended treatment is standard dose PPI. The patient does not need to be on high dose for 8 weeks. The PPI should then be stopped if the NSAIDs are also stopped. Question 2. The 24-year-old woman with a gastric ulcer has an H. pylori antibody and gastric biopsy is positive for H. pylori. She has a history of endometriosis and pneumonia last year for which she was treated with azithromycin. She is taking an oral contraceptive pill and has no medication allergies. What treatment regimen do you recommend for this patient? A, amoxicillin, clarithromycin, PPI for 14 days. B, amoxicillin, metronidazole, and PPI for 14 days. C, metronidazole, tetracycline, bismuth, and PPI for 14 days. And D, amoxicillin, PPI for 5 days, then clarithromycin, metronidazole, and PPI for 5 days. And E, amoxicillin, rifabutin, and PPI for 14 days. The answer is metronidazole, tetracycline, bismuth, and PPI for 14 days. This is bismuth quadruple therapy. Guidelines for treatment of H. pylori infection have changed due to concern for antibiotic resistance, especially to macrolides such as clarithromycin. If a patient has a clear macrolide exposure, as this patient did as she was treated with azithromycin last year, clarithromycin-based therapy should be avoided and quadruple therapy is recommended. In summary, NSAIDs and H. pylori are the primary causes of peptic ulcer disease, although there are other things to consider, such as a gastronoma. Patients can be asymptomatic, but they can also have symptoms such as abdominal pain, bleeding, which can be overt or occult, perforation, and obstruction. The diagnosis is usually made on upper endoscopy, but sometimes can also be made on upper GI series or CAT scan. Endoscopic treatment is performed for ulcers with high-risk stigmata. Treatment is then given with PPI, and this can be standard dose PPI for 4 to 8 weeks, depending on whether it's a gastric or duodenal ulcer. We then can stop the PPI if the inciting factor, such as NSAIDs or H. pylori, is removed, but we should continue the PPI if there's an unclear etiology or the patient needs to remain on NSAIDs and aspirin. We also want to make sure we restart aspirin for secondary prophylaxis within 7 days. For H. pylori treatment, there are new guidelines for first-line therapy. It's important to review prior antibiotic exposure, and we're more commonly using quadruple therapy. And we also can consider penicillin allergy testing to allow our patients to use amoxicillin, which is an important agent against H. pylori. Lastly, follow-up endoscopy is recommended for most gastric ulcers in 8 to 12 weeks. And we should also be performing H. pylori eradication testing, which can be done during the endoscopy or potentially with a stool antigen or breath test. And patients need to be off of PPI for 2 weeks for the stool antigen and breath test. I've listed a couple of supplemental references here for you to do some further reading if you'd like. Thank you very much for listening to this talk.